Okay, good morning everybody. So today I'm going to talk about OTC or over-the-counter medications or supplements, drugs that patients can go to the pharmacy and buy them and use them. So we all need to know about a number of them, about actually like analgesics, you already know the medications. They can be either OTC or prescription. So when we are talking about ibuprofen, naproxen, acetaminophen, those kind of medication like antihistamine medication for allergy, cold, you already know about those. Today I'm going to talk about some other products that your patients may be on them and they just use them on their own. And it's good for you to have some basic idea about how these medications work, what would be possibly adverse drug reactions, or are they really beneficial or not. Then we are going to work on our case. Right after we finish this, we can start the case, so you can leave earlier. And then, or you can stay in the class and be ready for next class. And then, question?
Yeah, is it possible for you to go over the first two tests?
Oh, the first two tests? Okay. Actually, I plan for next week, next Thursday, which I believe is the 30th. So when we are in class, we are going to finish the course with bronch, bisphosphonate-related osteonecrosis of the jaw, and then right after that, we are going to have a very comprehensive review for the exam, including the tests. So I'm going to go over the test next week, and other stuff, of course, to just make sure you have a good idea about the final. Not exactly the idea about the final, but good idea about the final. Okay. Exact is better, yeah. Okay, so OTC. One of the actually very common use of OTC medications, either topical or, for the most part, OTC is topical for acne, because if you are talking about any non-topical agent, oral agents are usually prescription medication. So in the case of acne, some patients try to use antibiotics, like oral antibiotics. Some, if they don't get a good response, then they wanted to use Accutane, which is a retinoic acid derivatives, and it's very effective. Those are all prescription medications. What we are talking today is about what's available for patients at pharmacies. So they can go to pharmacy and just buy the ointment, the solution, the topical one. So just a very little epidemiology about acne. About 90% of adolescents and 80% of, male adolescent and 80% of female adolescents. So it's a kind of teenage issue for the most part. So after these years, in mid-20s or so, the skin gets better. And the reason for that is what? Why teenagers? Hormonal, exactly. Hormonal surge, hormonal changes, and especially when you look at the numbers, 90% in male patients or male people, and then 80% in females. What's the reason for that? So why more common 10% is very significant? Testosterone, androgenic hormones in general. So when we are talking about acne, when we are talking about like male pattern, let's say baldness, these are all androgenic kind of type of hormonal effects. So acne, the same thing. So after a few years, the body gets adjusted to the hormonal changes and they get better and better. But in some people, it can be seen in like even 30s or 40s or even longer time. So that's why there are a number of products that people can use. Okay, pathogenic factor for the most part, as we mentioned, androgenic hormonal triggers. So in both male and female patients, if there is an androgenic surge from adrenal glands or like gonadal gland, then we have this kind of reaction. So excessive sebum production, alteration in keratinization process, proliferation of bacteria, Propionibacterium, and all these together cause a kind of like inflammation and infection process. So we have bacterial growth, we have hormonal induced sebum production, and the thickening of keratin on the top of the skin. So basically the bacteria and the sebum get trapped, and we have inflammation and infection. Diet also seems to be pretty important. So the studies were controversial about the diet. Some studies showed no, acne is independent from diet. So if it's happened due to hormonal change or genetic, it happens. But there are a good number of studies that mention with high caloric diet, the incidence of acne is higher. So like more sugar, more carbohydrate, more Western type of diet would be a trigger for people to have like more experience for acne, basically. And the reason for that is high caloric diet cause the secretion or like the production and secretion of insulin-like growth factor. And insulin-like growth factor causes the proliferation of sebaceous gland, and proliferation of sebaceous gland is one of the major cause of having acne, because production of sebum and also the bacteria together, it causes that inflammatory process. Keratinization and higher androgen synthesis. So with that insulin growth factor, insulin-like growth factor, we have all those other things happening. And that's very dependent on the diet. You know, just on the picture, I just wanted to show you acnes are in different types. So some of them are open comedo, they call it open comedo. It means that the top of the acne is very open. That's why this, the sebum inside that area gets oxidized. And that black spot is basically oxidized sebum. It's not dirt or anything like that. It's just the sebum which is oxidized because of exposure to the air. And then if we have closed comedo, it means the sebum is not exposed to the air, so it's not oxidized, but we have pus accumulation inside the acne, so we see these like white-headed areas. Let's talk about the first agent. Have you heard about this? Benzoyl peroxide. Very, very popular OTC, very effective OTC. So benzoyl peroxide is basically an antibiotic. It's an antibiotic, and fortunately, up to this moment, we do not have any serious report of resistance against this agent. So this is a still effective topical agent for treatment of mild to moderate acne. If you are talking about very severe inflammatory cases, most probably the patient needs to have systemic antibiotic. But for mild to moderate acne, which is not very like extensively take the whole like face or like upper torso, benzoyl peroxide can be a very effective OTC, at least over the counter. So there is no need for prescription for that. Look at the concentration. If you look at the concentration, 2.5 to 10%. And if you have free time, and let's say after final week, if you go to any pharmacy, to CVS or Walgreens, and look at the benzoyl peroxide, go to the skin section, acne section, and then look at the tubes of the cream, or like the pads or solution. Look at the concentration, you will see all different range of concentration. From 2.5 to 10%, you see more of efficacy. Of course, 8% or 10% is more effective. But if we increase the percentage that some of physicians basically order them to compounding pharmacies, the studies prove that there is no more efficacy if we increase it after 10%. So it does cause skin irritation, but there is no more efficacy. So 2.5 to 10% is the effective and therapeutic range. Anything more than that is not necessarily helpful. It's more irritating to the skin. Okay. Benzoyl peroxide prevents the development of treatment resistance. I just talked about that because basically there is no resistance reported to this agent, so we still can use this by its own, or we use this with oral antibiotics. I don't know if you heard or if you had personal experience, for people who have acne, sometimes physicians or dermatologists put them on periodical antibiotics. So not daily necessarily, but let's say the first 5 days of the month, or like 2 days per week. So periodic antibiotic, doxycycline, tetracycline, minocycline, or sometimes other antibiotics. So even with those antibiotics, a lot of people wanted to be on benzoyl peroxide also because it helps to prevent resistance to the other antibiotics, because it can treat the acne better or sooner, faster, so there is less chance to get resistance. So again, if I ask you about concentration, please be careful about the numbers. I rarely ask you to know the numbers, but in this case, it's needed to know because this is mentioned in one of your books, basically. I was reading the OTC section in Dental Hygiene Pharmacology book, and this was mentioned. So please know the percentage. Okay, for new users, just like many other skin products, possibly we wanted to educate the patient to try it on a smaller area of the skin and see if there is no reaction, if there is no hypersensitivity or possibly allergic reaction, then they can try on other parts. So there are a few parts of the face with acne, then they can try on other parts. One big important thing about benzoyl peroxide is it has a bleaching effect. So it may cause the discoloration of the clothes or hair. So that's another piece of education. And avoid sun exposure, so patient can use sunscreen. And what would be the order? So if in the morning, because usually benzoyl peroxide is used twice daily. So what would be the order? Sunscreen first and then benzoyl, or benzoyl first? Benzoyl first and then sunscreen. So because usually when we are talking about acne products, topical products, they cause skin sensitivity. So it's good for a person if he or she wanted to be exposed to the sun to have sunscreen on the top of it. The next agent, or this is a class of the agents that are in different brand names or different forms available in pharmacies, but this class is very important. And this is hydroxyl acid. So there are a number of different hydroxyl acids. They are in different forms, different dosage forms, and different names, different generic names and different brand names. But there are some common things in all hydroxyl acids. So they have cryotherapy activities. So they lyse the keratin, so that thick wall on the top of the skin that causes trapping the sebum and bacteria. They basically are cryotherapy, so they take care of that part. We have two major types of hydroxyl acid. We have alpha hydroxyl acids and beta hydroxyl acids. So the reason I put them here is you may see them on the back of the product in the active ingredient section. So when you see hydroxylic acid, it means these are cryotherapeutic and these are exfoliating agents. They cause exfoliation of the skin, of the top part of the skin, so that sebum is not trapped anymore. Less effective than other topical agents, and usually they are used when, let's say, somebody has acne. With oral antibiotic or topical antibiotic or even Accutane, they treat the acne and now there is a scar, there is hyperpigmentation. and they want to get rid of that, so they can use hydroxylic acid. In general, if the scar or hyperpigmentation is mild and very superficial, this is a good agent because it causes exfoliation. So if it's superficial, they can get rid of the area or the spot. Salicylic acid is one of them. Salicylic acid is a beta hydroxyl acid. So you may see a product, active ingredient, it doesn't say hydroxyl acid, it says salicylic acid. So it's exfoliating agent, and the effect is very concentration dependent. So the higher the concentration, the more effective, of course. Higher concentrations can be basically written as prescription, so the physician, dermatologist can write a prescription, or the pharmacy can compound it, but there are some concentrations that are available OTC. I don't want you to remember this concentration. The one that I want you to remember is 2.5 to 10% benzoyl peroxide. That's the only thing. This one, what I want you to know is the higher the concentration, they are more effective for salicylic acid. There is a caution with salicylic acid. If there is a large area of the body that a person wanted to apply salicylic acid, we need to be careful about adverse drug reaction. In general, when we are talking about a big body surface area, even with topical agent, we want to be careful about absorption, because if it's too large area, then the absorption is higher. So eventually we may see some systemic effects or adverse effects. So if somebody uses a lot of the salicylic acid in, let's say, upper torso or extremities or face, then if these things seen, it means the absorption was too high. So maybe the best thing is just go take a shower and get rid of all those topicals. Okay? So we just wanted to be careful about this. So please remember the signs of possibly systemic absorption of topical salicylic. In regards to complementary medicine, so if you go to pharmacies, there are also a section for complementary medicine, like more traditional medicine. And sometimes you see them at the same section with other medications. So for example, you see acetaminophen, ibuprofen, and then a herbal medication for pain or as analgesic. So sometimes they are mixed with other medication, and sometimes they are totally separated. So a couple of these are like tea tree oil. Tea tree oil is used for many different conditions, including dandruff, including acne, sometimes warts, or even cold sore. Tea tree oil can be used. And it's very interesting that a good number of studies showed that this is a really effective agent. Because a lot of time when we are talking about traditional or, let's say, complementary medications or drugs, usually we have no idea. So as a pharmacist, I usually do not recommend any of these because there is not a good background, there is not a good backup evidence behind this. But a few of them, studies shows a kind of like pretty acceptable efficacy. And one of them is tea tree oil. So it has antibacterial effects, it has antifungal effects, it has some antiviral and anti-inflammatory effects. So if the extract is a good extract, if it's a real tea tree oil, if the formulation is an appropriate formulation, it may work. Question?
As far as not having like concrete evidence, what would you consider concrete evidence? Because wouldn't them researching it and coming up with these be concrete evidence? Okay,
so the question is, how can we consider them as if there are studies, and the studies are good studies. So basically, if there is a study with good number of patients, and the method, the study design is acceptable design, so there is no flaw in the study, or the numbers are not manipulated, and you can see that the way they study, they explain how they got the results, then you can say, yes, there is something behind it.
Do you think there's any correlation with maybe these things don't make as much money in the industry as an actual prescription drug?
No.
So they don't do as much studies?
No, actually I don't see that reason. So the question is if there is not money behind this rather than like Accutane, which is a big acne medication. No, Accutane, we know scientifically, Accutane is a retinoic derivative. And Accutane dries sebum, totally. So that's a most effective cure. That's a cure for acne. And that's scientifically evidence-based. Something like this, we have a lot of small little studies from different parts of the world. First of all, we don't know how they did the study. We know the study in the United States, for the most part, are highly standardized. But in other parts of the world, not that they are bad, but we are not sure. And the other thing is, the numbers are not enough. The number of studies and the number of patients. So that's the real fact, I believe. And the other part, which is, to me, is the most important factor that usually I don't recommend natural products, because the other name for these are natural products, is there is no control in the content. So a tea tree oil, you buy it from this store versus that store versus somewhere in San Francisco, it can be totally different thing. So that's another
They
issue.
don't have to label what it is, sorry, right?
You know, they label it, but nobody basically supervise or inspect how they make it. They can label whatever they want. Yeah. Question?
So when you use tea tree oil, is it the same effect like with the sunscreen?
Oh, tea tree oil?
Yeah.
Yes, you know, in general, sunscreen is totally different.
Yeah.
So for any of these topical products,
Just put sunscreen over.
yes, use this first and then sunscreen on the top of that. But benzoyl peroxide causes irritation. So that irritation, for sure, the person, or hydroxylic acids. Hydroxyl acids, they cause exfoliation. So you want to have sunscreen, for sure, because the skin is more sensitive. Some products are oral, like capsule or tablets, like zinc. It has some anti-inflammatory, antibacterial effect, so it can be effective. You know, the list is, it's not that, it doesn't cause damage. Zinc, except for some GI upset or nausea, you know, it doesn't have any specific adverse drug reaction. So supplement for zinc should be okay. Okay, the next topic would be warts or verrucae. Verrucae or wart. Do you know what's the cause for this? Let me see if it's here. Oh, yes, it's here. So what's the cause? Just read it.
HPV.
Human papillomavirus. Okay, I thought it's not here. I thought it's in the next slide. Okay, so basically it's a viral thing, and so the close contact or even autoinduction. So somebody is playing with the wart here, and then they touch another part of the body, so there's another wart. So this is kind of like how it transmits, basically. Approximately 10% of general population have warts, so the incidence is not that low. And as you know, there is a vaccine available for HPV, especially for female teenagers. So it can prevent this kind of transmission in the case of wart or any other kind of skin or mucosal viral infection with human papillomavirus, which is overall is a very good prevention of cervical cancer, because we believe that that's the same pathology. So the same virus can cause the same thing or similar things. So we have a vaccine for this also. But again, risk factors I just mentioned, like biting fingernails or going with bare feet, you know, around the pools. And one big thing when we are talking about any viral infection is suppressed immune system. So people with like on immunosuppressive agents because of autoimmune disease or patients with HIV, or like post-transplant patients, they are at higher risk for having viral infections in general. Transmission person to person, fomite and auto-inoculation, as I mentioned, and it goes through minor skin abrasion and it affects basal keratinocytes. And usually it's a very superficial infection. It's not a deep infection. So it's kind of very top skin infection. Goal for treatment is to eliminate signs and symptoms, pain, and prevent transmission. So I'm not going to ask about this slide. These are just general prevention like recommendations, not to share towels, razors, socks, and shoes, and we all know that, okay? Treatment, these are the OTC. So as treatment, salicylic acid again, because it's keratinolytic, can be used. So we have this here again. Do you remember where else we had salicylic acid? To treat acne or hyperpigmentation after acne. Not really for acne, but to treat the spot after acne gets treated. So the same thing here, for wart we can use it. So in different concentration we can use it for different parts of the body. So if the wart is kind of like common wart, let's say on the face area, we can use 17%. If we have the plantar wart, which is harder to get cleaned or exfoliated, then we use higher concentration. And let's see the mechanism behind how it works is slowly destroy the viral infected cells. It's keratinolytic, so basically it just get rid of the cell which is infected, the whole area, and induce an immune response due to local irritation. So anything that can cause local irritation brings the immune system to that area, and that immune system can fight the infection. So that's another mechanism behind how it works. So this is one of the products, duofilm. So this is salicylic acid, and there is an applicator, and the person can just use it on the skin. The other product would be DMEP. DMEP is dimethyl ether propane, and that's a freezing agent. So again, there is an applicator. The person just spray on the applicator and put the drug on the skin, on the area, on the wart area, and it basically freezes the keratinocytes in that location. So a blister will form under the wart, and after about 10 days, the wart will fall off. Application must not be used for more than applicator. Applicator must not be used for more than once, of course. Compared to salicylic acid, cryotherapy, because this is called cryotherapy because we are freezing the area. Compared to salicylic acid, cryotherapy is not more effective. Every 2 or 3 weeks of treatment improves the results. And let's see what else has happened. Okay, at the very end, hypo or hyperpigmentation may occur. So please know these facts. The way I can ask question for these or things like this is in the form of true or false. So I can ask you a question, true or false. Compared to salicylic acid, cryotherapy is more effective. True or false?
The answer
False.
is false.
Thank you. The answer is false. Okay. And this is one of the products. And there are many others. So if I show you a picture of like one of the, this is just one brand. There are many, if you go to pharmacies, there are many, many different brands for this. Okay, in regards to supplements, vitamin A, retinoid, in general, vitamin A derivatives or retinoid derivatives regulate epithelial cell differentiation. That's exactly how they treat acne also. And inhibit HPV replication. So we have some topical or creams of retinoids for warts. Zinc supplement again can be used as just a supplement. So topical with zinc supplement may be even more useful. This is very interesting. This is not pharmacy, this is not pharmaceutical product, so you can go to Home Depot and get some of these. So occlusion with duct tape. Do you know duct tape? Okay. So you just take a piece of that and put on the wart. It causes irritation. It brings immune system to the area and it fights the wart, the viral infection. So that's how it works. So basically a piece of tape on the wart for 4 to 6 days and renew a day after for up to 2 months. So for up to 2 months, the person can use it. And that's how they use it. Okay? And actually, since it causes local irritation, it may be effective. So, next topic, herpes simplex labialis, also known as cold sore or fever blisters. So you may see patients, and I'm sure you will see patients, that may come and ask about, okay, if it happens again, what should I do to prevent more blisters or prevent the pain? So basically, again, like acne or other skin situations, if we have a severe herpes or if we have recurrent herpes, most probably the patient needs to be on acyclovir or valcyclovir. So a systemic antiviral medication, a true antiviral drug, and it's systemic. But if it's sporadic, like once a year or twice a year or once every 2 years, then there are some topical agents that can be used without being on acyclovir. But at any point, even if it's happening once a year or once every 2 years, if the acyclovir gets started early enough, like at the time that the patient feels tingling or burning before blisters are forming, it can be very effective, acyclovir. Okay. So HSV is primarily associated with labial infection, and after primary infection, HSV can be latent and be reactivated. That's very important. So if somebody gets infected once, the virus is there forever. It just goes to the ganglion nerve. So it stays there, it's dormant, it stays there, and when the patient is immunosuppressed, if the immune system is low, then it comes back through the nerves to the same location and causes the inflammation and blisters. HSV is contagious and is transmitted through direct contact. Virus is also viable on the surface of the objects for a few hours. So in dentistry, when you use devices, so they can be contaminated with virus, and the virus is viable for a few hours. HSV enters the host through the skin or mucous membrane and become latent in trigeminal ganglia. Trigger of reactivation can be any of the following. For the most part, we say stress or immune suppression, any of those. Okay. This is what we see. So usually on the border of the lips and skin, oral mucosa may be involved. I don't know if you see patient that oral mucosa or even nasal mucosa got involved. So a couple of times I saw patients in the hospital, they were extremely immunosuppressed though. And they had a cold sore and on the upper lip, and then it went all the way into the nasal cavity and it went up. So it was a pretty severe case. In those cases, we even need to put the patient on IV acyclovir to treat the infection. Okay. So for pharmacological treatment, analgesics of course, we can use analgesics, and we have many, many different brands of these things: benzocaine, dibucaine, and benzyl alcohol, and camphor. These are all different types of analgesics we can use. Some patients may even use topical lidocaine if it's available in different forms in pharmacy, like gels. They can use it, especially if it goes, it involves mucosa in the mouth. Let's see what else. Okay, so know about like topical analgesics, and this agent, Docosanol. Docosanol or Abreva. Abreva is the brand name. I think there are other brand names now for this agent, but this is the only over-the-counter antiviral agents that we have. So this is a true antiviral agent, and this is over-the-counter. We do not have acyclovir over-the-counter. We do not have valcyclovir over-the-counter. But this is the only antiviral that we can find in the pharmacy, and the patient can just buy it. So must be applied soon in prodromal phase, so when the patient has burning sensation but not blisters. 5 times a day application. In general, when we are talking about antiviral medication, they are pretty more frequent than other medications. Even acyclovir, PO, is usually 3, 4, or 5 times a day. It's not once daily medication. The other important thing, education for patient, is if secondary bacterial infection is suspected, so if there is pus around, then besides Docosanol, we need antibiotics, antibacterial agent, and they are also available over the counter. So they can take triple antibiotics and use them both. So if there is additional bacterial infection, they can cover both with having triple antibiotic and Docosanol. Have you seen Abreva, the tubes? They are very small and tiny, usually blue, yellow color. And the reason is it's very expensive medication to be prepared. And since it's a topical agent for cold sore, they don't want to have a big tube. So there is less risk of having like contamination of the tube. So one small tube for a couple times, and that's it. And that's the package of one of them. I think there are also more brands now. Okay, other pharmacological considerations. Avoid topical or systemic steroids, extremely important. Whenever we are talking about herpes simplex, it's very important to not use topical steroid, because this is viral infection. Using steroids, systemic or topical, it's extremely dangerous, because it may cause like the exacerbation, a severe exacerbation of the infection. So we have to be very careful about steroids, but what we can use are NSAIDs or acetaminophen. So if you have a patient with cold sore and it's painful and it's there, it's too late to use acyclovir or other, even Abreva is too late, then they can use NSAIDs or acetaminophen to at least relieve the pain and inflammation. When it goes to natural supplements, tea tree oil again is proven to have some antiviral effects. So again, the sooner the better. In prodromal phase, as soon as they have pain and burning, they can apply tea tree oil. Lysine supplement has a preventive effect against herpes simplex recurrence, and this is against supplement. What's that?
What's lysine?
Lysine is a supplement. It's like a kind of protein, but we can make it as a supplement. So you can go to a pharmacy, go to a supplement section, and that's like tens or hundreds of different of these things. Lysine, tyramine, different things.
That's still like natural? That's still
Yeah.
something natural? Okay.
Yeah, so we consider it as natural or supplement product.
Okay.
Yeah. So lemon balm can also be used to like reduce the symptoms, and these are all available over the counter. So please know the products, or please know what we can use. So if I give you 5 options, know which of these are using for cold sore. Halitosis or oral malodor or bad breath, basically, again, you may have patients coming to you for this reason, coming to dentist or dental hygienist clinic to ask what they can do to treat the bad breath. Up to 90% of cases are due to poor oral hygiene, so that's very important. So you can help a lot to prevent the situation. It can be due to dental caries, gingival infection, tongue coating, and impact food and debris, mucosal ulceration, and xerostomia. Many medications may cause xerostomia. So if the patient is on chronic, let's say gabapentin, or antidepressants, or antihistamine, those cause xerostomia, then that can be a cause of halitosis. Non-pharmacological care, of course, this is very important to know as a fact. Most fall breath odor can be due to volatile sulfur compounds, VSC. So sulfur compounds, especially in the tongue and gingival tissue, it can cause the odor. Prevention would be removal of plaque and prevention of caries. Brushing and flossing the teeth and brushing the tongue or using tongue blade can be helpful to clean these debris, basically. Okay, this slide, very important because it's all based on scientific evidence again. Zinc salts and chlorine dioxide are most effective chemicals for prevention of halitosis if we are talking about VSC or volatile sulfur compounds. So zinc salts and chlorine dioxide can prevent the formation of those compounds. And there are a couple products. One of them is a Smart Mouth, or the other is Closis, and maybe there are more, I don't know, but at least these two, they contain zinc and chlorine dioxide. So have you seen Smart Mouth? No, okay, that's kind of like a bottle, and there is basically a septum in the bottle. So there are two parts. So there is one part which is zinc salt, and the other part is chlorine dioxide. So when you pour that in the cup, basically both of them come, clear and green color. And it's very effective because it has both compounds. Okay. And this is the picture of, yes, the Smart Mouth. These are mostly more expensive than like regular mouthwash like Listerine or Crest or others. And the reason for that would be the clinical component, the two-piece that they are added, or the formulation. Okay, any question?
Why do they keep it separate? Is it like two steps? If you rinse with one, or do you combine them?
No, actually I think the reason they kept them, the question is why they are separated. So either like this, or it's in one container, but it has two heads. So when you pour it, they come from two separate parts, or totally separate container. The reason for that, I believe, is the chemical, like incompatibility. So maybe the two are not compatible. So we try to keep them separate until the time you want to use. Do you want to have a short break and then we continue? Okay. So 6 minutes. Okay. 6. I want you to remember 6 minutes. So please be here at 8:54.
That was so cute.
question. When we think something is keratin, it's keratinetic agent. What do you mean? What does keratin mean?
You know, keratinocytes are the hard cells, the hardened cells on the top of the skin or on the top of any mucosal surface. So when an agent is keratinolytic, it means they lyse, they clean that keratin. So
After it's there,
oh no, actually if the keratin is there, no, they wash it off. So it's not for prevention. It's mostly if it's there, they have to let it off. Get rid of it.
and when we were talking about the warts, one of those was the salt, right?
Salicylic.
Yeah, that's the salicylic. See, what is the form of it? Is it like a vaccine? Is it like a
Salicylic acid, you have formed as pads, so there are pads in the package, so there are salicylic acid on that, so we can use the pad, or like solution, or even cream, I believe. So there are creams.
But all that is like, okay, but the best way to treat this type of visual is because that's pretty much going to a doctor, right?
Higher concentration.
Yeah, or getting it like exercise.
Oh, I see. So they just remove. Yeah, actually they do that too. But the important thing is it may come back. So it's good to have also access to the OTC products. So if you feel there is a small that cryotherapy will be really key. You know,
Because when you go to the doctor, they actually do the crack.
exactly.
They do like
Nitrogen.
Exactly.
Exactly. They use a liquid nitrogen.
That normally works, but it creates what you call decoloration.
Usually the decoloration of the skin. Okay.
No, this is an example. Something like that.
Oh, this is after cryotherapy.
No, this was after.
Okay.
This one is not.
Okay. Which is
Try that one. Because already that one is hard to be consistent because when you apply it, you actually have to make the area like
okay.
you mess with it goes away.
Okay, but for how long? You have to.
It's like 4 hours. It's a lot. It's not
Easy.
if you're working, you're studying, you got
Oh, I didn't know it's 4 hours.
Look, that was so much long ago.
That's not your phone.
There could be something new.
Oh God.
I think it's good to try it. Let's go to a pharmacy and see what they say. Maybe we'll change the formula. Maybe we'll change the formulation.
It was so hard to see slightly salt. It takes salt.
I saw liquid nitrogen, which is used in processes. It's very good.
Yeah. That one is like you go, it's only one time.
Yeah. But unfortunately, we do not have what is called bleaching.
You actually have to go and pay.
That's the Oh, really?
Yeah, because some of them, they have standards. It's like this one, they will cover that. But if you say the local ones, the other are they don't seem to be
I think dermatologists are going to write the report in a way that it's therapy, it's not for cosmetic.
Yeah, well, what I learned is to go explain in a way. The way I learned, actually, in one of the teaching, the way they measure is something far not, if it's interfere with your social life or your working life. So I can work my pants. I need them.
That's a keeper. Yep.
I didn't want it. I was like, babe, I can wear my pants. And they were like, okay,
That's
you
not
can work with that. Yeah.
So they can find it.
I rollerblade too.
Oh no.
Well, try it.
I woke up and my phone was buzzing.
I got serious. Now I want to go to
And I was like, oops, I'm hanging up.
Are you, like sometimes like in the hall, like when I wake up early in the morning, there's like someone's alarm will go off like 20 minutes straight. Like all the time. Someone's alarm and it's like
I remember that ring.
He's like, how can you not wake up? Like I could hear it from your room. I can't imagine her roommates. I was like, oh my god. Like go wake them up. Oh really?
Okay.
Wow, that's good.
So let's continue with minerals and supplements. And today, for the most part, I'm going to focus on calcium, magnesium, and vitamin D, and other products for osteoporosis that we use for osteoporosis, and also arthritis. So when we are talking about calcium, it's a pretty complicated process in the body, calcium regulation. Intestines are involved when we are talking about calcium absorption. Of course, we are talking about intestinal absorption. Kidneys are involved because kidneys are the ones that produce the most effective form of vitamin D. And the vitamin D is helping absorption of calcium and utilization of calcium. So that's very important. One more thing which is very important would be parathyroid hormone. So if the patient has low calcium or low vitamin D or high phosphate, then we have activation of parathyroid gland, and then we have more secretion of parathyroid hormone, and that causes the resorption of the bone. Because parathyroid hormone, one of the major functions, is to make sure that we have enough serum calcium. So it takes calcium from anywhere possible. It increases the intestinal absorption, it decreases the renal excretion, and it also causes the bone resorption. So it brings calcium to the blood. It can be detrimental to the bone though, because it causes bone resorption and osteoporosis. In regards to calcium supplements, first of all, a couple of facts about calcium. This is the most abundant mineral in the body. So it's a very good true or false question. The most abundant mineral in our body, is it calcium, is it magnesium, is it sodium, or what? So it's calcium. Okay? And if you look at the proportion of the body weight, 1 to 2% of the body weight, 99% stored in the bone. So the majority, almost all calcium, is getting stored in the bone. The majority of adult bone mass forms by age of 18 in girls and 20 in boys. This is very important for all of us to know as healthcare professionals. So that's why we wanted to emphasize teenagers, kids, needs to have good dairy product, needs to be on good diet, to have enough calcium intakes, vitamins, because they have the majority of the bone growth and completion of the growth and bone mass during the teenagers. So if the person is not taking good amount of calcium during these years or early 20s, and then in the middle of 40s or 50s, they just start taking calcium, it's not that effective anymore. We want them to have them as early as possible. So even if you look at the numbers, I don't ask the question about the numbers, but it's good for you to know. So 9 to 18-year-old, 1,300 milligram. As the person gets older, the need is less until around like menopausal age or older age that they need more calcium again. but the highest number of calcium need is during the teenagers. Foods rich in oxalic acid interfere with calcium absorption. So if we are educating somebody to take some calcium supplement, we want to educate them, don't take them with spinach or beans or other foods with high in oxalic acid, like salad. If they take calcium tablet or capsule and right after that they get salad or spinach, it doesn't work that well because they interfere with the absorption. One other important thing, which is very important for me, for you to know, is this number. Most effective absorption is when we take 500 milligram of elemental calcium. If you take more, it doesn't get absorbed. So if you want it higher than 500 milligram elemental calcium per day, then we need to have it in different doses. So instead of one big dose, like 2 gram, we take it 4 or 500 milligram. Because the absorption is saturable. If you have a big dose, it doesn't get absorbed. So it's very important for higher doses to be divided to 2 or 3 times a day. And if you look at the majority of calcium supplements, the tablets, if you go again to pharmacy, a good thing about these products, they are all OTC. So we can go and get a bottle and look at the back, the active ingredients. Most of them, for example, it said 1,000 milligram calcium carbonate. But if you look at the active ingredient, the elemental calcium is much less. So if you take a tablet or a capsule of 1 gram of calcium carbonate, about 30 to 40% of that is calcium. The rest is other things. So when you take even 1 gram, you take at most 500 milligram. So as long as we don't take 2 tablets or 2 capsules together, we should be fine. Because the elemental calcium in almost all products is not going to be more than 500 for this reason. Okay. Different salts of calcium. Of course, we have different salts in the market. Calcium carbonate is the most common salts that you see. A good example of calcium carbonate is antacids, like Tums. They are calcium carbonate. Or other supplements that containing calcium carbonate. We also have calcium phosphate, lactate, citrate is the second most common one. So in the market or in pharmacies, you will see calcium carbonate, the most common, and then calcium citrate. And calcium citrate, it can be useful for people who are on antacids or PPIs or H2R blockers. And the reason for that is if somebody has higher gastric pH, it means their gastric pH is not that acidic. Calcium carbonate is not that effective. Calcium carbonate is not going to be absorbed. So then in those cases, we use calcium citrate. So if your patient has GERD and the patient is on protonics or pantoprazole for GERD, for reflux disease, what you want to recommend them is calcium citrate instead of calcium carbonate.
Okay, wait, I got very confused. So calcium citrate would work better for people with higher GI pH?
Yes.
Pretty much? Okay.
Yes. So if the GI pH is higher, it means the patient is on PPI or H2R blocker like antihistamines that suppress the stomach acidity, or they are on antacid. You want them to be on calcium citrate instead. Okay. Drug-drug interactions. Calcium is a bivalent cation, so it may bind to some of the medications. It has chelating effect. It's one of the most important chelating agents. So it binds to some antibiotics or some other medications and prevent their absorption. So we just wanted to make sure to educate the patient, if you take calcium supplement, take the other medication in 2 hours or 3 hours or at least 1 hour difference. So cotrimoxazole is another name for Bactrim, is another name for what? Do you remember? Cotrimoxazole, the very first one, is an antibiotic agent. The other brand name is Bactrim. What's the generic name for this? Nystatin? No. It's antibacterial. Clindamycin? No. No. Sulfamethoxazole? Do you remember? Trimethoprim? Sulfamethoxazole, trimethoprim? You don't remember? Don't worry. What do you need to remember? You know, for the test, possibly. Did you have antibacterial this quarter or last quarter? Last quarter? Okay, so don't worry about it. Sad. Okay.
Don't be sad.
Yeah. Okay. Fluoroquinolones. Do you remember fluoroquinolones? Cipro, Levo, Moxie. Let me ask you this question. It was last quarter, but let me ask you this. Which one of these is not respiratory?
What?
Cipro. Very good. Why?
We just guessed down.
All of them are oral agents. So ciprofloxacin, levofloxacin, and moxifloxacin, all of them are oral agents, or injectable, both. But Cipro, we cannot use it for pneumonia, we cannot use it for upper respiratory infections, for otitis. Why? What's that? It does not cover strep pneumonia. So it does not cover streptococcus. That's why we cannot use Cipro. Okay, but this is irrelevant to this topic. So for now, we wanted to focus on if the patient is on Cipro, if the patient is on levofloxacin, if the patient is on Bactrim or cotrimoxazole, if the patient is on moxifloxacin or tetracycline, we want to educate them if they wanted to take calcium supplement or dairy product, we wanted a distance, time difference of these agents because they have chelating effect. A very important medication that unfortunately a lot of patients don't pay attention is levothyroxine. Do you know levothyroxine? What kind of medication is it? What is levothyroxine?
It's a thyroid.
Thyroid. It's a thyroid hormone. It's thyroxine. It's thyroid hormone. So patients who are hypothyroid, who they have hypothyroidism, they are on levothyroxine. And levothyroxine with calcium, again, big interaction. Calcium does not let levothyroxine get absorbed. So it's very important. I always recommend patients that, family, friends, patients, to take levothyroxine because a lot of people are on levothyroxine. A lot of people may have thyroid dysfunction, so they are on levothyroxine. So take your levothyroxine early in the morning, separated from all other medications, separated from all other food, breakfast, everything. As soon as you get up, take your levothyroxine. After an hour or two, then take other things. Because this is a hormonal agent, it's very important. And the amount is very tiny. So if you mess up with absorption, then the whole treatment point is under question. Other medication, phenytoin. Do you remember what is the major effect of phenytoin on calcium? Phenytoin is sodium channel blocker. But what's the effect? Do you remember when I talked about phenytoin? First of all, what is phenytoin? Antiepileptic. Okay. Do you remember if a patient is on phenytoin, the patient needs to be on very good calcium and vitamin D supplement. Because phenytoin is what?
Sodium blocker.
Sodium channel blocker. Yes, thank you. But in regards to metabolism, phenytoin is an inhibitor or inducer? Inducer. So it induces vitamin D metabolism. So the patient has less vitamin D level, so we have to give the patient more vitamin D and calcium supplement. So it's very important again for you, for all of us. We don't need to wait for a physician to say that to the patient. If you have a patient on phenytoin and you don't see calcium and vitamin D supplement, you must tell the patient, you need to be on calcium and vitamin D supplement. Because if you don't do that, then your young patient, your 25-year-old patient, get osteoporosis when he or she is in 30s. So it's very important. And it's very easy to fix. Calcium and vitamin D. So, iron, another thing that we have interaction with calcium. Can you guess what would be the interaction? They are both bivalent medications or bivalent cations, so they compete in absorption. So again, if the patient is on iron supplement and on calcium supplement, we don't want to take them at the same time. Just 1 hour or 2 hour difference, that's fine. So please know about what's the nature of the drug-drug interaction. Question?
So if you can't take like calcium and iron at the same time, how does a multivitamin work?
Okay, that's a very good question. I always ask the question myself. So when we are talking about all these interactions, why we have multivitamin with zinc, calcium, iron, and everything? We assume some of them get absorbed. And we have pretty good amount of these in multivitamin. So even if they compete each other and they prevent each other absorption, we have some absorption. But I always recommend the patients, if you have osteoporosis and if you take Centrum, you have to take another calcium supplement. Because in the Centrum you have iron and all other cations, so the calcium may not be absorbed that well. Or if you are taking Centrum and you are anemic due to iron, you need to have iron separately. So do not just count on Centrum. That's a very good question. It doesn't mean they don't get absorbed, it's just less. Okay. Okay, calcium supplements, they may cause some GI problem, and let's see. Okay, the big one is constipation. The most important one is constipation. So that's why in a lot of calcium supplements, they also added magnesium to balance the constipation. So if you go to, let's say, Costco, you see big bottles of calcium. It says calcium, vitamin D, and magnesium. Magnesium is added to help blood supply to the bones and muscles, and also to prevent constipation. Vitamin D supplements, we talked about vitamin D in the past. But as a supplement, basically, let's see. When we are talking about vitamin D insufficiency or deficiency, basically if somebody has low vitamin D levels, it causes reduced intestinal absorption of calcium, which is not good. It also increases the PTH, and what is PTH doing? Parathyroid hormone. It causes bone resorption. So if somebody has low vitamin D levels, then we have more bone resorption, which is not good. Okay. So that's why, basically, we wanted to put the patient also on vitamin D supplement. And we talked about vitamin D in the past, so you know. Daily vitamin D, 400 units or 800 units, that would be good enough. And especially with calcium, it's very effective. Magnesium supplement, the most important thing about this would be, first of all, magnesium is a part of the bone. It has mitogenic effect on osteoblasts, mitogenic effects on osteoblasts. Is it good or bad? When we are talking about osteoporosis, it's good.
Because it creates more bone.
Yes, exactly, because osteoblasts form bones, osteocytes. So if it's mitogenic on osteoblasts, it means we have more bone formation, which is good. Magnesium depletion causes cellular growth inhibition. And look at the fourth bullet. Calcium maintains bone strength, while magnesium maintains its elasticity and prevention of injury. That's very important. So it's not just calcium supplement to have good bones. It should be magnesium also, because it causes some kind of flexibility or elasticity. So it prevents the fragility of the bone. So it prevents the, basically, fractures. Also, magnesium is a cofactor which is involved in vitamin D synthesis and calcium metabolism. So you see how important is this cation. So it's not just calcium. Again, when we are talking about osteoporosis, we want the patient to be on magnesium also. Okay, I don't ask about the numbers here. In regards to some interactions, basically, there are some medications that cause low magnesium level. Diuretics like Lasix. Do you remember what's the generic name for Lasix? Furosemide. Do you remember furosemide? Loop diuretic. Furosemide. So it causes low magnesium, low calcium, everything. So if the patient is on Lasix or furosemide or any loop diuretics, we have to be careful about magnesium and calcium supplement because they may have low levels. Hydrochlorothiazide. You remember what was the effect of hydrochlorothiazide on calcium? Increase. Very good. So calcium was the only mineral that hydrochlorothiazide caused increase in it. Others like magnesium, potassium, everything goes low. So we have to be careful about magnesium level when we take these medications. Cisplatin. Do you remember where did I talk about cisplatin? Last week? Oh, we didn't finish. You didn't tell me anything. You think you're smart. We didn't finish the antineoplastic agents. But we are good. We have time. Don't worry about it. We finish it. Cisplatin. So we didn't talk about this. That's why you don't know it. Cisplatin is one of the antineoplastic agents. It may cause low magnesium. Okay, Miss President, why didn't you tell me? You were my friend. Okay. Okay. Gentamicin. Gentamicin is an antibiotic. So again, it causes low magnesium level, which is not good. So if somebody is on high doses of gentamicin, we wanted to make sure that we check magnesium. If the patient needs more, we give supplements. Amphotericin, do you remember what was amphotericin? Antifungal. It's an antifungal agent. It causes low magnesium also. So if a patient is on any of these medications, we need to have the patient on magnesium supplement. That's the whole point. Okay. Magnesium oxide has the highest amount of elemental magnesium. So again, just like calcium, elemental part is more important. So the like different salts of magnesium, I want you to know that magnesium oxide has the highest elemental. Bioavailability of magnesium oxide is lower than magnesium chloride and magnesium lactate. And one major adverse drug reaction is diarrhea. So with calcium we have constipation, with magnesium we have diarrhea, that's why we mix them together. For the first two parts, what I want you to remember is mag oxide has the highest amount of elemental magnesium. That's the only thing I want you to know. Don't worry about bioavailability. And the last bullet. So major adverse drug reaction of magnesium is diarrhea. Question?
Why do magnesium supplements may be required in alcoholics? The past slide. It says magnesium supplements may be required in...
Oh, okay. Because in alcoholic patient, the patient may have low levels of magnesium and vitamins, so we need to give them supplements if they're alcoholic.
I have a question on that side. Are the magnesium supplements, do we need to memorize each one of those that are low in magnesium? Those ones?
The medications, yes, these medications, yes. Because they are all lower the levels of magnesium. So if I ask you which of the following medications lowers the level of magnesium, if you see one of these, definitely choose them, pick them. Okay, glucosamine. Glucosamine is a precursor for aminoglycan found in synovial fluid and ligament. So when we are talking about glucosamine, we are talking about basically arthritis and possibly osteoporosis, but for the most part, arthritis. Exogenous glucosamine is derived from marine exoskeleton, and it has some anti-inflammatory effect. And another fact that it's very important for us to know is glucosamine sulfate is preferred over glucosamine hydrochloride. The reason I say that is, if you ask your patients if they are on glucosamine, if they check the bottle of the medication, the majority of those glucosamine in the market is glucosamine hydrochloride. Glucosamine sulfate is more expensive, and the difference would be the absorption. Glucosamine sulfate gets better absorption to synovial fluid and bone and cartilage than glucosamine hydrochloride. So which one works better? Sulfate for sure. So that's very important point to know. There are trials that compare glucosamine with other analgesics or anti-inflammatory agents, and I just wanted to summarize this whole slide and let you know that a good number of trials or studies proven that glucosamine has good anti-inflammatory effects. So it really reduces the pain. So when it goes back to the studies that you mentioned, we have pretty good number of studies behind this. In regards to the allergy, some patients mentioned that they have shellfish allergy. For the most part, if there is a real allergy, is not to the shell. Most allergic patients have reaction to the meat, not the shell, not the exoskeleton. So they should be okay with glucosamine. Even if somebody has fish allergy, they should be okay for the most part. The other thing is, some patients are concerned about having diabetes and using glucosamine. Glucosamine does not affect blood sugar or does not affect hemoglobin A1C significantly. So it should be safe in patients with diabetes. It may increase blood glucose slightly, but it does not majorly affect the disease control. So it should be okay. If they get benefit, if they have less pain, if they can move or walk better by using glucosamine, it's good to use. And the dose, the only thing I want you to remember is, since it causes GI upset, some patients cannot tolerate it because it causes GI upset, we wanted to give it slowly. So we start with low dose and we increase the dose slowly. So we titrate the dose up. Good. Oh, okay. It causes like pain and irritation of the GI.
Because I take that medicine, but I didn't know that those.
You take glucosamine?
Yes.
Okay. You know, a lot of people, they don't get GI upset. But if you get high doses at once, let's say if you get 1 gram or 1500 milligram at once, it may cause some GI irritation and pain. If it happens, then you can make it in smaller doses. Okay. That's okay. Chondroitin is another supplement we use to basically improve the joint structure. But the whole point for this slide is there is not enough evidence behind chondroitin that prove that this is a very effective supplement. That's the only thing I want to know about this agent.
Can you repeat that?
Chondroitin per studies, it's not proven to be very effective. That's the only thing I want you to know. So you may see a lot of products, or you may see patients on chondroitin and glucosamine together. That's fine. It doesn't hurt. But the important fact is it's not effective at the same time, at least per studies. And we all rely on the studies when we are talking about treatments. Okay. There were studies that compare glucosamine and chondroitin versus glucosamine alone, and in those studies they didn't see any difference. So adding chondroitin or not that much of difference. MSM or methyl sulfonylmethane, basically, again, you will see this a lot in different products for bone and joint health. And again, back to the evidence-based medicine, there is not that much of robust study behind this. So adding MSM to glucosamine or calcium or other formula, it's okay, but in regards to effectiveness or efficacy, not that much of evidence. So far, glucosamine is fine, it's good, it's effective. Chondroitin, we don't know. MSM, we don't know. And the last agent is SAMe or s-adenosylmethionine. Clinical trials shows reduction in arthritis pain. It increases chondrocyte, which is good. Chondrocyte, the cartilage part, the cartilage layers, it increases them or proliferation, and decreases inflammatory cytokines. So it's anti-inflammatory. So this is a proven medication that helps reducing the pain and forming some cartilage, which is good. Okay, let's see. Okay, look at the last two bullets. There is a time lag of 6 to 8 weeks before seeing the results. And this is a general rule for this and glucosamine, both. So if the patient or if the person takes glucosamine and he or she expects to see good joint or better bones, it takes time. It's not immediate. It's not like NSAIDs or acetaminophen that you see the effect in a couple of minutes or a few hours. The other thing is the same for SAMe. It takes a few weeks to see the result, to have less pain. So it takes some time. It also, there is a caution. It increases serotonin, norepinephrine, and dopamine levels. So if the patient is on antidepressants, that they contain medications that increases dopamine level or serotonin level or norepinephrine level, we need to be careful about this. Because too much serotonin or too much norepinephrine is not good. It may cause hypertension or other symptoms that are not good. So we just want to be careful about that. And just to see the picture of one of the products, and it's usually among like higher cost or like more expensive arthritis or joint medications. Okay, so if it's okay with you, let's see. Can we just go back? Do you have the slides for antineoplastic agents? Just please open the slides for antineoplastic. Yes, chemotherapy.
We're almost done though. Right. Just like 3 more slides.
I believe we finish. Did we finish hemorrhagic cystitis?
We were at 39.
39? This one? Febrile neutropenia?
Yeah.
Okay. Okay. So febrile neutropenia, again, we are talking about antineoplastic agents. They affect any kind of highly proliferative cell lines. So if the patient is on antineoplastic agents, is that any question back there? Are they right? Yeah. Oh, I see. I thought you were thinking about this is not the slide we were talking about. So this is the right one? Okay.
Yeah.
Okay, great. I'm getting Alzheimer's, so please help me to remember which one is which. No, I'm teaching different classes, and some of the topics are extremely similar. So that's why I'm asking. So when we're talking about febrile neutropenia, first of all, the reason for febrile neutropenia is myelosuppression effect of chemotherapeutic agent. That's number one cause. These agents affect the bone marrow. So they cause suppression of white blood cells, red blood cells, platelets, all those cell lines. The other thing is we are talking about immune deficiency, because when we are talking about lymphoma or other blood kind of cancers, the patient may have a lot of lymphocytes and they are not functional. So the patient is immunosuppressed, naturally, unfortunately. And a lot of time, we also talk about mucositis. So the patient is on anti-neoplastic agent, it causes mucositis, it causes irritation and inflammation and ulcers or opening of the GI mucosa. At the same time, the patient has low immune system. So all together causes the translocation of bacteria from inside the GI to the blood. So that causes the febrile neutropenia. It means the patient is neutropenic and the patient is febrile now. It means there is infection somewhere. Febrile neutropenia is a medical emergency. So we need to treat it as fast as possible, as soon as possible. And we need to use very broad spectrum of antibiotic. This is a need to be treated, to treat the infection as fast as possible. When we are talking about empiric treatment, do you know what's the difference between empiric treatment and prophylactic treatment? Because you use prophylactic treatment when you are talking about endocarditis. So if the patient has the history of endocarditis, or if the patient has prosthetic valve, if they come to you and you want to perform deep cleaning, you may want to prescribe a dose of antibiotic. That's prophylaxis. So what is prophylaxis? Prevent. What is empiric? What's the difference? What did you say? You were right. Okay. Okay. So it means the infection is there, but we don't know what exactly is the infection. We cannot necessarily know what type of bacteria it is, but we know there is something. There is infection for sure. There is a gram-negative infection, but we don't know. Is it Klebsiella? Is it E. coli? What is it? So in order to treat that infection, we need to use a broad spectrum antibacterial agent. So that's empiric treatment. Okay? This is when we don't know, we don't have the culture. If somebody comes to the hospital with nausea, vomiting, a lot of headache, what do you suspicious of? If somebody comes to the hospital with a lot of headache, nausea, vomiting, what kind of infection you worry about?
Viral.
Viral. Usually it's bacterial because it's very acute. GI, headache. Headache. Do we have headache with a lot of GI enteritis? No. How about meningitis? Meningitis. So if somebody comes to the hospital with vomiting, headache, and disorientation, the patient is not oriented, then we think about possibly meningitis. So we have to start empiric treatment. We don't know what's exactly the cause, but we know it's mostly gram-positive. So we just start with a very broad spectrum gram-positive coverage until we get the culture. But we don't wait for the culture. So that's empiric treatment. And I want you to remember, for febrile neutropenia, we also use empiric treatment. So we don't wait for any culture. And the last slide, empiric treatment, when we want to start it, we want to consider a number of facts. First of all, we need to know what is the hospital antibiogram. What is hospital antibiogram? Okay, so hospital antibiogram or a clinic antibiogram is, we wanted to see here at Loma Linda University Medical Center, if we are talking about Staph aureus, what percentage of that is MRSA, what percentage of that is sensitive to penicillin. If we are talking about E. coli, what percentage of E. coli that we are dealing at Loma Linda University Medical Center, what percentage of them are resistant to Cipro, what percentage are not. That's antibiogram of the hospital. It means we wanted to know in this center how we treat our patients. It may be different if you go to San Francisco and go to UCSF Medical Center. The antibiogram may be different. So for the same disease, we use different empiric therapy based on the hospital antibiogram. Patient history is very important because a lot of time patients have recurrent disease, the same organism. So it's very important to know if we had a patient with cancer, the patient went through chemotherapy, and the patient had infection after a few weeks of chemotherapy. And the infection was E. coli. Usually patients come back with the same infection. So it's good to know the history. Potential site of infection is very important. Is it lung? Is it bladder? Is it blood? Because then we use different antibiotics. We need to cover Pseudomonas. So Pseudomonas coverage is a must. So in the exam, if I ask you which bacteria needs to be covered when we are talking about febrile neutropenia, that's Pseudomonas, for sure. If the patient is clinically unstable or hypotensive, it means the patient is most probably in shock. So we need to even broaden the spectrum, use more gram-positive, gram-negative bacteria, antibacterial agents. The other important thing is allergy profile. If your patient is allergic to penicillin, you cannot use a big number of antibiotics. So again, back to you as clinician, it's very important when you get allergy history or allergy information from your patient, be careful. Ask them a few more questions to make sure that's true allergy. If your patient has nausea and vomiting to penicillin, it's not allergy. So do not report it as allergy. Because if you do that, and if your patient get in the ER, emergency room, for meningitis, and they see the patient is allergic to penicillin, they cannot use ceftriaxone. They cannot use a good antibiotic that they could use. So it's very, very important. Prophylactic regimen is also important. Prophylactic regimen is preventive regimen. So if the patient was on, let's say, penicillin, and the patient is febrile on penicillin, it means penicillin is not effective. Because the patient was on antibiotic, and on the top of that antibiotic, the patient got infection. It means whatever we choose was not effective. So we have to change. We have to switch to another antibiotic. And, okay, again, the empiric antibacterial regimen must have a very broad spectrum, and we want to start it as soon as possible. So if the patient goes through chemotherapy, after a few weeks, the patient neutrophil goes low, the patient gets febrile, that's emergency situation. They come back to the hospital, we start antibiotic. Questions? Okay, I'm happy now, so we finish this. Okay, so the only thing that is left is brunch for next week, and the review. Okay, case. For today's case, let's just make it more like there's a show here. So please come to the front. Sandra, Trisha, Brian, Kevin.
Oh, okay.
I've done that before with somebody else.
What's that? Actually, if you can come here, so students can see you. Oh, yeah, it's okay. Can you see the screen? Good? Okay. Wonderful. Okay. We are still waiting for... Who's not here?
Well, you put two, you put first
Sandra?
and the last name of two different people. Well, Naveen's middle name is Sandra.
What's that? What's that? Sorry. Did I put a wrong name?
It's Naveen, but then
Anna, I'm gonna stand right here.
Okay. So, who wants to come here?
I'm already here. Yeah, we did.
Okay. So let's go over the first case. Your patient is at the clinic for his appointment for deep cleaning. The dentist wrote a prescription for a dose of triazolam, 0.25 milligram, to be taken orally 30 minutes prior to procedure. Your patient just remembered that he took a dose of 10 milligram diazepam the night before for insomnia. So the patient took diazepam last night for insomnia, to just sleep better. And today, the patient is at your clinic at 10 a.m. and the patient has 1 tablet of triazolam. Okay, who wants to answer this? I want to ask the question. Brian?
Okay.
Do you ask the patient to take his triazolam or not? Because the patient had diazepam last night.
Okay. So it's 10 a.m. now. What are the prescriptions for dose?
Triazolam is 0.25 milligram, and
Okay.
he has the medication.
Okay. Yes.
Okay, you still want him to take triazolam?
Yeah.
No.
So you said yes. May I ask you why? What's the rationale?
Short acting.
Short acting. Very good, I like that. What else? Okay. What else? What else you see here that it gives you a peace of mind that, okay, I know the patient was on diazepam, but I want to ask him to go ahead and take triazolam. So what else you see here toward the end of the case?
Okay. The patient was, he took a dose of 10. Is it the dose?
The dose is pretty not too low, not too high dose of diazepam, but the fact that the patient took it
The time.
time, yeah.
Okay.
He took it last night. So yes, it's sedative and it's good for a day or so. But if the patient is at your clinic at 10 a.m., it's enough time. So the majority of the effect is clear. So if you want to have a sedated patient, you need triazolam. So it's very important because it happens. Patients come to you and they say, you know what, I don't want to take my Halcyon because I got my Ambien last night. Okay, that's totally different. You took your Ambien to sleep better, but you're here now. If you want to be sedated, you need to take the triazolam. Okay, thank you very much. Thank you. That was great.
Good job, Brian.
Thank you. Thank you. Case 2. Your patient has a traumatic molar tooth extraction. You expect your patient to experience severe pain and inflammation for 2 to 3 days. What options do you consider for your patient? Who wants to answer? One of them.
Here. What do you
Kevin?
take? Ibuprofen?
Okay, so first of all, your patient has a traumatic procedure. So a lot of pain and inflammation, and the duration is 2 to 3 days, so it's not that long. So for sure, Kevin, you have more than one option. So can you go over any options that you think about? You mentioned one, ibuprofen. Okay, so if your patient kidney function is good, if your patient doesn't have history of GI ulcer or bleeding, what kind of dose do you recommend to your patient? Low dose, high dose?
I would recommend high.
Yeah, moderate to high dose, and that's totally fine. Because you're talking about 1 or 2 or at most 3 days. So it's totally fine. So do you remember what kind of dose is that? Do you remember?
Over 1,500 milligrams.
Very good, over 1800 milligrams.
Because that's
So,
when inflammation kicks in.
exactly. So the higher the dose of ibuprofen or any other NSAIDs, we have more anti-inflammatory effect. So if you want to fight inflammation and pain together, you want to go with high dose. Let's say 600 milligram or 800 milligram 3 times a day, or even 4 times a day. And remember, if you want to recommend that, be sure that your patient does not have renal disease, and your patient does not have GI disease. Because if you leave the patient with high dose ibuprofen and GI, then the patient may come back with GI bleed, which is not good. Okay, so ibuprofen, moderate to high dose, one option. Let's say your patient say, you know what, I don't want to deal with NSAIDs. I don't like ibuprofen or naproxen or any of those.
Just tell them it's not that then.
It's not possible.
It's not an option.
You have
You
options.
just give them the brand name and they won't know the difference.
Oh, okay, very nice. So, trick them. Just give them the brand names. Okay, you don't like ibuprofen, take some Advil. That's nice. Don't do that though. Okay, so how about other options? A lot of pain.
You could go with
Opioids?
you could go with nitrous treat. Oh, I mean, wait, no, that wouldn't work. You could go with
Oxycodone.
Oxycodone. Okay, do you give oxycodone by itself or in combination?
Combination.
Combination. What is the combination?
Starts with an M.
So oxycodone with acetaminophen.
Oh, yeah.
So the brand name is Percocet, and it's prescription for sure, but it's another good option. So for short term, it doesn't do anything with inflammation though.
Oh.
You agree? It doesn't do anything with inflammation. Any other option? So oxycodone with acetaminophen or Percocet is pretty strong medication.
You could give them like Benadryl or something for the inflammation.
Benadryl. Do you think Benadryl helps pain and or inflammation?
No, it won't help with the pain, but it would help with the inflammation.
Inflammation? Benadryl?
Wait, no, you're right. I'm thinking of something else.
So hydrocodone with ibuprofen, I forgot.
Okay, very good, very
The
good.
name.
Another, I don't know the brand name too. So another good option is hydrocodone or oxycodone, any of those, with ibuprofen. Because ibuprofen can take care of inflammation, and then oxycodone or hydrocodone is analgesic. So that's another option. And unfortunately, I don't know why we don't see that combination that often.
Quick question. Would Vicodin work in that case?
Yes, actually Vicodin is another option. So he mentioned oxycodone with acetaminophen. Vicodin is the brand name for hydrocodone with acetaminophen. So the reason I asked this question is I want you to just can think about different options. So if the dentist is agreed to write a prescription for any of these combinations, that's fine. If not, ibuprofen or naproxen. If the patient has a lot of pain, you can use combination of ibuprofen or naproxen and acetaminophen. That's a very, very good combination. And unfortunately, some of the colleagues are afraid to give them together to patients. They say, you know what, try acetaminophen. If it doesn't work, then try over. No. Just give them together. Those are different medications. You are not overdosing your patient. Just give them together, let the patient be pain-free. So one thing I want you to remember is if you're recommending any NSAID to your patient, again, be careful about renal and GI. Make sure the patient does not have renal disease or GI. Okay. Case 3. Do you have any concern about the following medication? So you have a patient with this profile, lisinopril, dextromethorphan, ibuprofen, warfarin, nifedipine, apixaban. Oh, I like this case. I can see a lot of red flags. Okay. One of you who wants to answer?
Okay, I'll do it.
Okay. So from the top, lisinopril. Do you see any problem with lisinopril?
No.
No.
I
You
mean,
look better.
it's a ACE inhibitor.
Very good. Yeah. So the patient has hypertension, possibly it's an ACE inhibitor. Very good. But the next medication,
Dextromethorphan.
read that.
Chronic.
For chronic.
Oh, so it's not as needed. It shouldn't be as
Yeah.
needed.
No,
Or
actually,
it should be.
I should.
It should be. There's nothing wrong with dextromethorphan.
The
But
dosage?
You
no,
can't
no,
take
the
it together.
indication. It's for dry cough.
Yeah, it's just for,
Very good. ACE inhibitor cause dry cough.
Mm.
So you have a patient on an ACE inhibitor, and the patient is suffering dry cough. And the patient is taking dextromethorphan to treat that dry cough.
okay,
So that's a sign that maybe it's due to ACE.
then we can switch it to.
Exactly. Then you can switch it to another antihypertensive medication. This is very, very common that we see patients on ACE or ARB, they come back with dry cough. And it bothers them. It's not a bad allergic reaction. It's just bothering. So if he or she has to take dextromethorphan for that, just switch the medication. Okay? Ibuprofen. Do you see anything wrong with ibuprofen?
The dose is okay because so it wouldn't be under toxicity for the dose.
Mm-hmm.
But they are taking it with warfarin, which is also another blood thinner.
Okay, so that's a kind of, yes, you want to be careful about that. You want to at least ask the patient why they take ibuprofen. Another thing in ibuprofen I don't like, in ibuprofen order. If I see that, there is something that I want to ask.
Oh, why they're taking it continuously?
Very good, very good. Why it's not PRN?
Yeah.
For pain medication, it can be okay. You know, you may ask your patient to take ibuprofen 200 milligram POQ 6 hours for 2 days. You may want that. But I want to ask just to make sure. I don't want to let the patient go with being on ibuprofen Q 6 hours forever. That's not good. Okay? Warfarin. Do you see anything wrong with warfarin?
What's QD? Daily? Okay.
Oh, yes, QD is daily. Yeah.
Okay.
And warfarin is anticoagulant, so I don't see anything necessarily wrong with that. The patient probably have AFib or a stroke, something that needs to be on warfarin. Nifedipine.
Now that's the that would cause gingival hyperplasia.
Exactly. So it doesn't necessarily mean that it causes gingival hyperplasia, but you want to check.
It can cause.
Exactly. So you want to make sure the patient doesn't have that issue. The last one.
So bad. What did you say?
An A-band is a
Exaban. And Exaban is a
it has to do with the liver.
liver. No.
It has to do with I'm trying to remember.
You know, if I wanted to remove something from this and it's emergency, that's one of these medications that we're talking about.
Yeah.
Apixaban is what? Do you remember what kind of medication? Anti?
No.
Antioxidant.
No.
Anti?
It's
Anticoagulant. Anticoagulant.
Yeah.
So it's anticoagulant. So it's just like warfarin. So you have a patient on 2 anticoagulants. It's absolutely wrong. We have no indication. We have no medical situation at all that you have warfarin and apixaban together. There is something wrong here. So we need to. The only time that you may see this is if the patient is on apixaban, the cardiologist wants to switch that to warfarin. And since it takes time for warfarin, exactly. That's the only thing. But if it's a mistake, it's a big, big mistake. So one was lisinopril, the other one was ibuprofen, which is a schedule. We don't like that, unless they want it. And then nifedipine, you have to be careful about gingival hyperplasia, and 2 anticoagulants. You definitely want to question that. It's very important. Thank you. Last case. Any concern about this case?
Are there any GI indications? 'Cause they're taking celecoxib and naproxen using the same drug.
Very good, very good. That's definitely, most probably an error. So the patient may go to 2 different physicians or a physician, a dentist, and each of those prescribed for one of these. And the pharmacist didn't pay attention, so the patient is on 2 NSAIDs. That's wrong, okay? What other duplications can you see here?
Amlodipine and hydrochlorothiazide, those are the hypertension medications.
It's okay, you have 2 different antihypertensive medication, hydrochlorothiazide and amlodipine. You have a lot of patients on 2 or 3 antihypertensive. Look at the first medication.
That should be just once, right? Daily?
Okay, antobrazole, okay, very good. So first of all, it's twice.
Oh, and it's not as needed.
Very good. So thank you very much. It should be once daily, first of all. Pantoprazole is a once daily medication, and it shouldn't be as needed. Pantoprazole works slower, so it's for maintenance.
And then shouldn't the naproxen be as needed, or no?
Very good. So we ask the question again. Just like ibuprofen, the previous case, we want to ask, do you need to be on naproxen every 6 hours? Is there a reason that you wanted to be on this medication on a schedule? Your physician, your dentist, whoever said that. If they have a reason, that's fine, for shorter. If there is no reason, that's definitely an error. The third thing is ranitidine.
Isn't that the same as the pseudo?
No. Ranitidine and pseudoephedrine are not the same. But ranitidine is an H2R blocker. So you have an H2R blocker with a PPI. To me, it's a question. Do you need PPI? Do you need H2R blocker? They both are used for GI and reflux. So most probably the patient doesn't need both. And if you look at, you don't know the dose of ranitidine, but the dose is it's overdose. It's very, very high dose. And the last problem is the last medication.
So rebound congestion can happen, but it says for every 6 hours as needed, so that's confusing.
Do you see rebound congestion with this?
No, but if they took it regularly, like it says, if it's saying take
Okay.
every 6 hours, then after 3 days you can get rebound congestion.
This is PO. You have a very good, you mentioned a very good thing, but you remember it was the topical one. So if the patient spray nasal pseudoephedrine, after 3 days we have rebound congestion.
Oh.
This is tablet. The patient is taking tablet.
So there's hypertension.
Hypertension.
Yeah.
Especially if the patient comes to your clinic and you see pseudoephedrine and the patient is on antihypertensive medication, it's not good because the patient already has hypertension. The patient is treating hypertension and then he or she is on 30 milligram Q6. It's a lot. So this patient definitely has episodes of hypertension after taking pseudoephedrine. So these are all things that you may see when patients come for different reasons to you, not for medications. But as you review the medication profile, you can prevent a lot of disastrous events. Okay, any questions for your friends? Everything's good? Thank you very much. Thank you all. Thank you. Thank you. Okay, I see you next week for the review and run. Thank you.